Good afternoon. My name is Captain Pati, and thank you for giving me the opportunity today to speak to you about limited opioid ERAS protocol for bariatric surgery. Here is our standard disclaimer, and none of our authors have any disclosures. As many of us know, enhanced recovery after surgery protocols integrate evidence-based practices and utilize multimodal perioperative interventions, which are designed to reduce physiological stress and accelerate recovery in patients undergoing major surgery, with the aim to return the patient to normal physiological function as soon as possible. ERAS protocols emphasize a reduction in opioid use and a shift toward multimodal analgesia. Multiple recent studies and the ERAS Society have determined that ERAS protocols adopted within the field of bariatric surgery have the potential to reduce morbidity, expedite recovery, and reduce the length of stay. By implementing the principles of ERAS into bariatric surgery, there is the potential to improve short-term recovery and long-term outcomes. The opioid crisis is a term that refers to the rapid increase use of prescription and non-prescription opioid drugs, particularly in the US, that began in the late 1990s. In 2017, opioids were responsible for 68% of all drug overdose deaths. Results of a recent Michigan study indicate that the rate of new persistent use of opioid pain relievers in bariatric patients was more than 45% higher than in general surgical patients. Additionally, nearly 1 in 12 patients who did not take opioid pain medications until their weight loss operation report that they are still using prescription opioids 1 year postoperatively. Therefore, we felt that bariatric patients are a target for interventions to reduce opioid usage, but we were concerned that may prolong their hospitalization due to less pain control. The objective of our study is, does a limited opioid ERAS-Bariatric protocol reduce the number of post-operative morphine equivalents per day without increasing the length of stay? Our study is a historically controlled retrospective one comparing 2 cohorts of patients undergoing bariatric surgery at a single institution. Those in the standard care pathway underwent surgery between August 2015 and December 2017. On January 1st, 2018, the ERAS-B pathway was instituted, and those patients undergoing bariatric surgery from then through September 2018 were included in the study. The electronic medical record was queried for, Here, in order to standardize how much opioid pain medication was used, a conversion to morphine equivalents was performed. Then the morphine equivalents per day was calculated as depicted here. Of note, the hydromorphone patient-controlled analgesias, PCAs, were calculated at 2 milligrams or 8 morphine equivalents per day, which is likely an underestimate. The electronic medical record was queried for the data collection points as listed here, including demographic information as well as BMI and procedure type. This compares the standard care protocol with the ERAS-B protocol in the preoperative phase. Notably, the addition of pre-anesthesia non-opioid pain medications, including IV acetaminophen as well as PO gabapentin. In the intraoperative portion of the pathway, the most notable differences are that we performed a laparoscopic transversus abdominis plane block with liposomal bupivacaine, and the Foley was either not placed or removed before leaving the operating room. Here are the orders for the immediate postoperative time period, and I like to highlight the multimodal analgesia, as well as the antiemetic agents that we used in the ERAS-B pathway. Here depicts the progression of the bariatric pathway diets. As you can see, the ERAS-B patients are started on a stage 0.5 diet immediately postoperatively after recovering in the post-anesthesia care unit, while the standard care are only started on a diet if the upper GI series was negative the following morning. Some important key differences between the pathways were that the earliest standard care patients could discharge was postoperative day number 2, while ERAS-B patients could discharge a day earlier if their diet was advanced per protocol. As stated earlier, intraoperative adjuncts such as the TAP block and postoperative multimodal pain control are the crux of the ERAS-B pathway. After reviewing the data, we performed an uncontrolled analysis and a controlled analysis which excluded the patients undergoing the upper GI series. In the uncontrolled analysis, the study population consisted of 97 standard care patients and 61 ERAS-B patients. The majority of our patients underwent laparoscopic Roux-en-Y gastric bypass, as you can see here. The results of our study in the uncontrolled analysis are that there is a statistically significant difference between the standard care and the ERAS-B groups with regards to the number of morphine equivalents per day, with a mean difference of 11 between the two groups. Additionally, we showed a statistically significant difference between the standard care and ERAS-B groups in the uncontrolled analysis with regards to length of stay, with that being an entire day difference. However, we expected this because we no longer performed an upper GI series routinely on postoperative day number 1. Here's a graphic representation comparing the two groups in the uncontrolled analysis, showing that less morphine equivalents per day were used in the ERAS-B patient group, as well as less length of stay. In order to control for a prior practice pattern that required a routine postoperative day upper GI series, a repeat analysis was performed with all patients that underwent postoperative day 1 upper GI series removed. There were 84 patients total in the controlled analysis. 30 were standard care patients, thus removing 67 who underwent the upper GI in that cohort, and 54 were ERAS-B patients, removing 7 patients that underwent upper GI on postoperative day 1. The results of the controlled analysis show that there is still a statistically significant difference between the standard care and the ERAS-B groups, with that being nearly less morphine equivalents per day of 10 in the ERAS-B group. Here, the controlled analysis data shows that there is also a statistically significant difference between the groups in length of stay, with that being a half a day difference. So as you can see, removing the upper GI series patients still shows a statistically significant reduction in morphine equivalents per day and shorter length of stay for our ERAS-B patients. We are the first study to demonstrate an objective decrease in morphine equivalents per day using an ERAS-B protocol for bariatric surgery. Some of the limitations of our study include the type of study it is, that is an unblinded, retrospective historical control, the small sample size, the fact that opioid analgesic equivalency is an uncertain conversion and fails to account for individual tolerance, and lastly, that we weren't able to track the PCAs retrospectively. In conclusion, implementing limited opioid ERAS-B protocols can reduce opioid use postoperatively without increasing length of stay in bariatric surgery. And therefore, we think that due to the risk of persistent opioid use and its known deleterious effects, limited opioid ERAS protocols should be further studied and implemented. Here are my references, and mahalo for your time.